Good morning. This is Dr. Nettleman bringing you For Your Health. I have today Dr. John Feldman, a urologist at South Shore Hospital. John, why don't you introduce yourself? And you have been on the program, I think, twice. As a matter of fact, I think you were actually the first person that I interviewed 15 years ago, whenever it was.
And it's a miracle we're still on TV.
That's right, and we're still on TV.
They gave you a second run.
And this is, I think, the third time you've been on, and you're going to bring us a new topic of gene therapy in prostate cancer.
Phil, first off, it's truly a miracle gave you a second show if I was the first show.
Yes.
I'm going to discuss gene therapy today a little bit and how it relates to prostate cancer because I find it fascinating. I think it's a very interesting topic for discussion. And I want to start with a story, and this is a true story. My roommate from college, when we were sophomores, his mother developed what was termed an aggressive form of lung cancer by biopsy. They lived outside of New York. His father was a physician, and they got her, and she had metastatic disease, and the prognosis was dismal. And they got her into some experimental protocol for lung cancer at Sloan Kettering. And they took 100 people and they gave, in a similar situation to her, and they gave them all this chemotherapy, this new experimental chemotherapy that was going to save the world. And it was an abject failure. 98% of the people with this lung cancer who got this therapy were dead in 6 months. There were 2 people that survived, this woman and somebody else. This woman, they called the drug a failure. They never pursued it, never brought it to manufacture, but the company continued to make it and give it to her and the other patient out of compassion. And this woman died about 6 months ago, 28 years later, in her sleep, and the lung cancer was still very much present in her lungs, and the lymph nodes were still enlarged, but it never progressed, it never changed. My understanding is, because my friend told me this, that the other patient lived about 15 years and died of something else either. They're now looking at it and they realize that what happened is this chemotherapy was very effective against people that had a certain genetic abnormality that caused the lung cancer. It doesn't work in the others. To really oversimplify it, there may be 4 steps that have to go wrong in protein synthesis in the cell to create a lung cancer. I'm way oversimplifying. But the thing is, at the end of the day, if it's step 1, step 2, step 3, or step 4 that goes wrong, the cancer under the microscope, to our best technology, looks the same. And we call it adenocarcinoma of the lung or squamous cell lung, whatever. And hers looked the same. But on a genetic basis, she had a defect at step 1 in that process. And it turns out that defect is seen in 2% of people, not coincidentally, and it worked great for her. They're now actually bringing this chemotherapy back to market to manufacture to test. But before you get on it, if you're diagnosed with lung cancer, the studies are saying, we got to do the genetic testing to see if you have that defect. And then they give it to you.
Of course, they didn't do, or were unable to do, the genetic testing originally.
It didn't exist.
Didn't exist.
And so that's the genetic, that's the background to where I find this fascinating and where the value comes in. So this woman lived, and they are finding preliminary studies in those men and women with that lung cancer, with that genetic defect, who get this chemotherapy. They do phenomenal. But that's only 2% of people. There are 3 or however many other steps there are to develop lung cancer, or steps that can go wrong to give you lung cancer that looks the same, and this chemotherapy won't work for them, but there are other chemotherapies that will. This has incredible potential, which is real and being utilized now in managing care in 2 ways. Number 1, various medicines and chemotherapy are being developed and adopted and working to address the protein synthesis fault in the gene at the other steps. And this is happening in kidney cancer and in prostate cancers and in lung cancers. And we're seeing some really incredible results throughout the field of oncology, not just urology, which is incredible. And for example, and this is why I find it so exciting, metastatic renal cell carcinoma, metastatic kidney cancer, used to be uniformly fatal in a very, very, very short time period. If you had lymph nodes that were involved and lung metastasis, 3-6 months and it was over. That's the way it was when I started to practice. I personally, in my limited experience, because in this day and age you don't find a lot of people presenting with metastatic cancer anymore, thankfully, I have 3 patients who presented to my office with widely metastatic renal cell carcinoma. They underwent the genetic testing and they are getting chemotherapy to address that genetic defect in the gene to slow progression. Now they're not cured, but they are, one guy is out 3 years, the other guy is out 5 years, and I don't remember how long the other woman is out.
Could we back up a minute, and could you explain to the audience what genes are and what gene testing is?
Okay, so genes are the DNA code that tell the cell how to produce proteins, and these proteins do different things. They reproduce, they utilize energy, they derive hormonal transmission, make hormones or utilize hormones. Genes are the backbone of the cell.
And they're on the chromosomes.
They're on the chromosomes. And the genetic testing looks at these genes and sees where's there a mistake. So we have a renal cancer. What gene went wrong? Where did it go wrong that it's not like normal? So we take a biopsy of Phil Nettleman and we run the DNA analysis and we see that this is your pattern. And everybody has a very, very, very similar pattern on the gene sequence that controls kidney cells. But these people have an abnormality, and this abnormality results in cancer. Gene testing is when you do an analysis to find out where's the defect. And it may be that your defect is at position 8, and this drug will work for position 8. That patient's defect is at position 22. Now that has real value in that I no longer am going to waste my time or yours giving you a drug, a medication, a chemotherapeutic regimen that A, is toxic, B, causes you significant side effects in time and makes you feel sick, and C, we now know isn't going to work for you. I'm going to target only those things that have any real chance of working.
So very customized.
Precisely.
Yeah.
And this is beginning to be utilized in common practice in certain cancers. For the audience, you know this, DNA is billions and billions of sequence chromosomes, and this is not something that can be analyzed inexpensively. It is not something that can be analyzed easily yet. It is not something that can be analyzed quickly yet, but it's getting there. It's close. It's approaching. And when it does, the potential is real and huge. And we're, as I say, we're seeing results in kidney cancer. We're seeing them now. We are coming up with, we know that this gene isn't working. We're coming up with this chemotherapy or this medicine to address that. And it's incredible. And this isn't the same chemotherapy, by the way, that we used 10 years ago. This is not the chemotherapy that you would inject that would cause cell death. And so every dividing cell would die. The dividing cells in your hair, the dividing cells in your gut with the nausea and vomiting, you go bald, etc. These aren't the dividing cells. We're not addressing that. We're addressing the defects. So in addition to not giving you medication that we have every reason to believe won't work, we're going to give you medication that's dramatically less toxic. So this is an incredibly exciting development in medicine. The potential is huge. So that's one way we're using it. And we're already using it in kidney cancer, as I said. Others will come very shortly. The other real benefit to this is that this genomic testing is to identify which genes have gone wrong, especially in prostate cancer. You and I have talked about this before. Some prostate cancers are going to take 30 years to kill you if you totally ignore them, and all I have to do as a urologist is stay out of the way and not get involved. Other prostate cancers are probably going to kill you in a year no matter what I do. And I've never seen one yet in 25 years of practice that hasn't presented with widely metastatic prostate cancer, and they don't respond to anything. Most cancers, of course, are in between. But there is genetic testing now that we are doing to determine, this cancer under the microscope, which is a relatively crude way to evaluate the aggressiveness of a cancer. It's valuable, it has real potential, I mean, it has real value, it's time proven, but it's crude. This looks like it's an incredibly slow growing cancer. It looks like if I just stay out of the way, it'll never bother the patient.
This is the Gleason score.
This is the Gleason score of 6, or the grade of 3 plus 3 equals 6. That's correct. I'll come back to that in a second if you'd like. But it looks like it's a slow-growing, relatively harmless cancer. Just stay out of the way. We are now sending those patients, we're sending their biopsy specimen for genetic testing to confirm that this has low lethal potential.
Are you doing this on a regular basis?
More and more every day. More and more.
What percentage would you say you're sending now for
I would say I'm sending 5 to 10% of my prostate cancers that are low grade for genetic testing. And I'm doing that to confirm that I can safely observe the patient. Why aren't I doing it with everybody? So let's go back a little bit. I told you a minute ago that some prostate cancers are very, very slow. Some prostate cancers are very, very fast. And then you said that's the Gleason score business. So let's review the Gleason score. A pathologist named Gleason about 50 years ago noticed that prostate cancers are not all the same. Some look very, very benign. Some look very, very poorly differentiated and aggressive. And he came up with a score sheet where they're graded, Gleason grade 1, 2, 3, 4, or 5, depending upon how they look. And many, many, many studies have correlated very strongly that the higher the grade, the more aggressive the cancer. And in every pathology lab in the country, you have a glass slide sitting on a microscope, and right above the pathologist's head, as you know, is a diagram with the Gleason score so every pathologist can look at this. But that's crude. So the people that I'm using these studies on are the people that I am thinking are very good candidates for active surveillance and doing nothing, and just watching them, but also because, quite frankly, they are not FDA approved yet. They're not covered to a large degree because they're just not quite ready for prime time, and I'll come back to that in a second. I am using them in those patients that I think have a long life expectancy. If a patient comes into me and he's 85 years old and he's had 2 heart attacks and 3 strokes, and he's got an elevated PSA, and he's got a low-grade cancer, I'm not worried about 15 years from now. If he's 50 years old and running marathons, he may have a low-grade cancer, slow-growing cancer. But frankly, I got to worry about 15 years from now, and that patient is the guy that I'm sending the DNA analysis on.
At the same time, if you have a high Gleason score, there's not too much question about what you're going to do.
That's correct. You need
If
treatment.
you have a very low Gleason score, again, you'll comfortably watch it.
Well, that's the
it's
point.
these large groups in the middle.
No, I'm going to disagree respectfully.
Go ahead.
That's the problem with the active surveillance protocols. A small but real percentage of patients who you put on an active surveillance protocol because you think they have a slow-growing cancer will be found in 1, 2, or 5 years to have an aggressive cancer.
Okay.
And I just don't know today which ones those are.
What about the ones in between, though?
They need treatment.
Any treatment?
They need treatment. Then we get into a bigger discussion. Different
But you
discussion.
won't watch these people with
No.
Gleason's 4, 5, or 6.
Gleason score 4 or 5. No, I'm sorry. Gleason score in 25 years, I've never seen a Gleason 5 score. I see grades of 5, I see grades of 3, but as a practical matter, it is incredibly rare for a variety of technical reasons to ever see a Gleason grade 2. So as you know, the score is the most aggressive and the second most aggressive, or if they're the same, it's just twice that. I never see 2 plus 2 equals 4. I never see 2 plus 3 equals 5. Every cancer I've seen in the last 25 years, no, come out from our pathology lab as 3 plus 3 equals 6, 3 plus 4 equals 7, 4 plus 4 equals 8, 4 plus 5 equals 9, or 5 plus 5 equals 10. I'd never see scores of 5. Haven't seen it out of our lab 25 years.
Really?
So those people that have any 4, any Gleason grade 4, which is a score of 7 or 8 or higher, they have an element of aggressive cancer that has the potential to be lethal in a shorter time frame. Those people are not candidates for active surveillance.
So it's the gene testing that you use on your very low grade cancer.
To make sure they're not one of the ones that look low grade but really aren't.
And these represent 5 to 10% of your population?
5%, 5 to 10% is a guesstimate.
Yep.
Of the low grade cancers. So
Right.
you have 100 people with prostate cancer, making the numbers up entirely. 20 of them have the low grade cancer. 1 or 2 of them will have an aggressive cancer despite looking low grade.
Okay, let's say you've identified those patients. And what are you looking for? A defect in a particular gene?
I was hoping, as I walked in the door, Phil, I hope he doesn't ask that question.
Yes.
Because then my knowledge dips down dramatically. But yes, we're looking for defects in specific genes.
Can you say, is it one particular gene or is it a number of them?
I believe it's a number of them. But I at this point, we're getting way above my pay grade.
Okay. All right, so basically, what kind of report would you get back from wherever you send this?
Well, one of the reasons that there's nothing approved, there are 10 different companies that are marketing different testing for this, and they all give you different results, and it's unclear which one is the best. It's unclear which one is the most accurate. It's unclear, and there's more testing that has to be done. So it has to.
So it's very, very much in the beginning stages.
But it's incredibly exciting.
So it's basically the difference between not treating and treating.
Correct.
With your available options of treatment.
As using gene testing and genetic testing today for prostate cancer, yes.
It doesn't tell you what would be the most effective treatment.
It does not.
Yeah.
It does not. But I suspect also that may come to be.
Yes, I believe that will be too.
As you know, to give you an example, as you know, the primary therapy for metastatic prostate cancer is hormonal therapy.
Yep.
And for the audience, testosterone, which is produced by the testicles, feeds, for lack of a better word, prostate cancers and causes them to grow, etc. And hormonal therapy is the removal of the testosterone from the system, one way or the other, and that has clearly been demonstrated to result in dramatic slowing of prostate cancer growth for a variable period of time.
Doesn't cure anything.
It doesn't cure anything, but it slows it dramatically in most people. There will be genetic testing very soon. Which people doesn't it slow it in? Which people should we not bother a trial of hormone therapy in? That's coming down the pike.
So it sounds like there may be a whole new class of drugs that come out for the treatment of prostate cancer that is genetically identified, other than what you have now.
I would expect that, but that also to speak with authorities above my pay grade. I can tell you that as regards renal cell carcinoma, that has already happened. They've identified the gene defect. They've identified a medication, for lack of a chemotherapy, a medication, a treatment that pinpoints that genetic problem and addresses it, and they're getting great results.
Well, this is a difficult question, but prostate cancer, for instance, if you have metastases, You use hormone therapy to suppress,
That's correct.
but you don't have any chemotherapeutic agents such as you might use with colon cancer or kidney cancer.
No, we do have a chemotherapeutic agent,
What is that?
Doxetil.
And
It's
when
not-
do you use it?
You use it today, and this is very much in flux. You use it today generally when the hormone therapy is beginning to not be as effective.
Okay.
And it's been shown to add significant time, it's been shown to add significant survival time and good quality of life. And it's a relatively, and I say relatively because none of them are zero, relatively benign chemotherapeutic agent. There are other newer medications that we use, as you may know, I'm sure you do, excuse me, which address intracellular testosterone, which is a whole new process. It turns out that I give someone hormone therapy, and over time, after a period of years, usually multiple years, their cancer becomes resistant to the testosterone suppression. And it turns out that that happens because there is a significant amount of testosterone which is produced by the adrenal glands. That's a small amount, but also intracellularly, and we give medicines that block that also.
Again, a hormone.
Souped up hormone therapy.
Okay.
And this is going to help to be much more precise in how we address cancers in the future. And also, it's clearly going to have a great role in addressing other cancers besides the urologic, which I can speak to, but to like the lung cancer that my friend's mother had.
Let's go back now. How does this topic that you've been speaking of, this information, have any effect on your practice today?
Yes.
How so?
Number one, I am able to take people that present, and again, this is thankfully an incredibly small number, who present with metastatic renal cancer or who develop metastatic renal cancer, and I can recommend them for these gene therapies that the medical oncologists give, and they're incredibly effective. And that's today, and these have been developed directly from that.
That's metastatic.
Metastatic.
But what about the patient that I send to you with a PSA that's going up?
Right now, that's not, I have no application of gene therapy in that
So
setting.
you still have to do the prostate biopsy. Might you ever, I mean, I read where they're taking the biopsies from prostates and doing gene therapy on them, or gene testing.
Genetic analysis.
Pardon?
Genetic analysis.
Yes,
technical.
genetic. Is that something that might someday be routine?
Well, first off, let's go back. That's exactly what I was talking about when I'm saying those people that have what I'm putting on active surveillance.
Right, with
And
low grade.
Yes.
Right.
And I think I'd be amazed if within 10 years it is not routine, to better enable us to predict A, prognosis, B, treatments.
Even on the highly aggressive.
Yes. Yes, I do. I really would expect that.
And I would think that will probably come about if treatment becomes very customized.
That is where medical oncology is going.
Yeah.
There are 3 problems right now that I can think of offhand to massively widespread use. Number one, currently incredibly expensive. Incredibly expensive. And as a society, we simply can't afford it until we've demonstrated that therapy, that the genetic analysis and the customized therapy adds significant quality of life survival years, because it would take away so much from everything else if every person with cancer underwent this analysis. When in most cases we have, for example, if you have testicular cancer, just to take one, Testicular cancer, as you know, is incredibly highly curable. It is incredibly rare, almost non-existent, but not zero, for someone in 2015 to die from testicular cancer. We have incredibly effective treatments, even in the face of widespread metastatic disease. I'm blanking, of course, the bicyclist who cheated with the steroids, Lance Armstrong. Naturally, I'm on TV, and I'm going to blank the whole thing. Lance Armstrong had widely metastatic testicular cancer. He had metastasis in the brain, and here he is 25 years later doing fine. He has been cured. I don't know that we need to spend the time, the effort, or the money on genetic analysis of routine testicular cancers when we have an incredibly effective treatment for it.
In the remaining 2 minutes, I'm going to ask you a question that I get asked at least once a week. What about these things that they advertise on TV? Super beta prostate, saw palmetto, do they play any role in the younger person with an enlarging prostate?
I would say to you 3 things. The first thing I would say to you is any of the FDA-approved medications for prostate treatments must be covered by the insurance companies, and they result in not millions, but billions of dollars of income to the company that manufactures it. If these drugs were effective, if these over-the-counter things that you're talking about were effective, these manufacturers would go to the FDA, get approval, get a patent, and get billions of dollars from the drug company.
But they're
billions.
making a lot of money as is.
But they're making money, it's been not as much. That's number one. Number two, there was a study done about 5 years ago that showed that none of the over-counter medications, none of them have any difference with placebo or any benefit, period. Number three, they did an analysis of the pills. The most common one is
super beta prostate.
But what's the active ingredient?
Saw
palmetto. They did an analysis. They bought a box of saw palmetto. There were 30 pills. They're supposed to be 30, making the numbers up, 30 milligrams per pill.
Yeah.
They found that one pill had 900 milligrams, the other 29 had nothing.
But the question is, does it help?
And the answer is unequivocally, the data shows no benefit.
Okay. So even if it's very concentrated, and you know how much it is, the saw palmetto itself, you don't believe it has any effect?
The literature, double-blind placebo-controlled studies have failed to demonstrate any benefit over placebo.
Good.
At anything at all except lightening your wallet.
Well, again, I think we're just about at the end, and this discussion has been a little more involved than our previous ones. I hope that the audience has been able to follow our topics a little bit and have some understanding of the genes and chromosomes and what the future holds for many of us. Again, I thank you very much for appearing, and this is number 3, I believe. And if you have any more topics, Dr. Feldman, please feel free.
Phil, I want to tell you, I'm honored that you've had me the first time. I was honored the second time. I continue to be honored.
Thank you very much. This is Dr. Nettleman for your health.